Tonight, let's begin. Tonight, we're so happy to introduce Dr. Anthony Goodman and his wife, Maribeth Goodman. This evening, they will engage in conversation together, talking about his new book, Great Saves and Terrible Losses, The Journeys of a Surgeon. He's born in Brooklyn. Brooklyn in the house. Dr. Goodman has had a remarkable career as a general surgeon. He received his undergraduate degree at this pretty good school called Harvard, and did his medical residence at the University of Michigan and Harvard. So who do you like best, the crimson or the blue? Okay. After more than 20 years in private surgical practice in South Florida, Tony began a second career of 30 years as a professor at a medical school in Montana. During this time, he has also authored 2 books of historical fiction and a book for women about breast cancer. Additionally, he was a professor for the Great Courses. How many people have used the Great Courses? Wonderful. With this new book, he once again leads the way in speaking openly about another diagnosis, this one with himself as a patient. He also shines a light on healthcare system that is constantly changing with insights into how to navigate that system. I think his best accomplishment of all this was his marriage to Maribeth.
That was not in the notes.
Which goes to show you her work was as important, if not more important, than his work. So please welcome Tony and Maribeth.
Thank you all for being here. A lot of familiar faces. Now I'm going to have to learn lots more names. I thank you all for coming. Can you hear me in the back?
No.
I've got about 5 minutes worth of voice, and then I get so hoarse.
A little louder. You're not reading just yet.
Oh, okay. Can you hear me over there? Okay.
Great. So I'm going to open with a question, and then Tony's going to read a little from the book, and then we're going to have a conversation about a few topics. Can you all hear me okay? Yes. Great. So a lot of people ask why you wrote this book, Tony. You started writing it in the early 90s, which I think a lot of people didn't know. And I'm curious, Tony, about what compelled you initially to write this book when you moved to New Zealand.
Well, I arrived there with nothing else to do, so I thought I'd write a book. But actually, I really wanted to look at my whole career. I looked at the whole thing now that I was no longer an operating surgeon when I got there, and just as a consultant and someone people talk to. But I realized I didn't know what was involved in my education and the whole residency program and then the Army Surgical Corps. So I decided that I would write this book so I could see what it was about, my family could see what it was about, especially my children and grandchildren when they learned to read, and put it out there for the public.
And you took a memoir writing course at the time, am I correct?
I did. I took a memoir writing course in
Christchurch.
In Christchurch, yeah. And got together with another woman who was taking a writing course with me, and together we met every day for coffee and breakfast, and then we went out and read each other's stuff to each other, and then went out unmercifully with what we thought should be changed.
Right. And you continued writing the book when you moved to Montana.
I did.
Yeah. And since then, Tony's written 2 other books, and this particular book sat in his computer for several decades. And he worked on some other things, and it was after his diagnosis a few years ago that I decided I wanted that book published. So I pulled it out, and our wonderful editor did her magic, and so many other wonderful people came along, but it's had a long gestation, let's just say that. But the next question Tony often gets asked is, why did he become a doctor? And so there's a chapter in the book that he's going to read that I think tells you a little bit of that story.
Short chapter. It's called A Broken Heart. Brooklyn, New York, 1951. The bird was lying on the pavement under an elm tree that grew in my section of Flatbush in Brooklyn. It looked more like a fetal pig than a bird. It had no feathers and all pink skin. It was less than 3 inches long. In fact, if it hadn't been such disproportion, it didn't have such a disproportionately large beak for its size, it would have been hard to tell it was a bird at all. It was very cold and it was very dead. That year was 1951. I was 11 years old and walking to my 6th grade class at Public School 193 in Brooklyn on Avenue K, it's Bedford Avenue, for those of you who know. This was the Midwood section of Brooklyn. I picked up the little bird and I looked up. I wanted to see if I could find the nest, but the foliage was just too thick. I put the bird in my pocket and continued along the 5 blocks from my home to school. It's odd to look back at that time and realize that as children growing up in Flatbush in those days, we all walked to school alone. We had friends to follow us to keep us country, but our mothers generally waved goodbye from the doorways and we went to school by ourselves. Nobody snatched children in those days, as far as I can remember. We never worried about it. It was not something that came up, even in Brooklyn. The streets were safe for us. Nobody thought really anything about it. When I got to school that day, I walked directly in to see my teacher, Mr. Rausch, who was a great big man, or so he seemed to an 11-year-old. And he had a huge smile, I remember most of all. He had big hands too, and wore the same brown suit all the time. Mr. Rausch was a sensitive man and nurtured my growing interest in biology and in medicine. We all had to do special projects from time to time, and for mine, I would cut out the articles in the medicine section of Life magazine and glue them to a poster board. I would then explain to the class the workings of whatever system that Life magazine were putting out that week, and they were featuring in their magazine. It all ended abruptly. I had to do a poster on human reproduction. There was no sex education in the schools of Brooklyn in 1951, so this was a little avant-garde even for Mr. Rausch, but he let me go on with my show. The problem was that at 11 years old, I didn't have a clue as to what really happened during human reproduction. Any reproduction for that matter, so as I was just parroting what I had seen in some very schematic drawings, my understanding of human sexuality turned out to be really zero. About halfway through the lecture, my friend, Chris, raised his hand and stood up and said, "How does the sperm get to the egg?" That was a very good question. I hadn't really thought about it myself because I was too preoccupied with getting all the glue in the right places on my poster. It was a damn good question. I hemmed and hawed for a few seconds and finally I said, "Through a tube." I had remembered something like that in Life magazine in the schematics, or maybe it was something I overheard my older brother, who was 8 years older than I was, saying something to his high school friends. The day finished without my hearing another word from our, I did, sorry, that didn't sound too good. Well, yeah, oh, sorry. Where did I stop? Are you sure? I read that already. No. There? Oh, he said what you draw. Well, anyway, we, did I say we opened the oh, that's what we did. Okay. So we picked up the bird, I brought it to school. Mr. Rausch let me get my instruments and my friend Dickie, and we set out newspapers and opened up our case of instruments. I laid out the instruments on the table, being very self-conscious, because I didn't know the proper order in which they were placed in a real operating room. For me, this was not going to be an autopsy, but it was going to be an operation. It didn't matter that the patient was already dead, and probably stay that way. I was about to do my first surgical operation. We opened the jar, took out the bird, and the fumes from the formalin made our eyes tear. That gave me a chance to play doctor just a little more. I took out 2 white handkerchiefs I had brought, and Dickie and I tied them over our mouths and noses. We told everyone that the mask would have stopped the smell, which of course it didn't. But nevertheless, deep inside, I was a surgeon in a real operating room, and these were our masks. I had rubber gloves appropriated from our kitchen, also to protect us from the chemicals, and these 2 I wore with pride. We laid out the bird because of his oval shape. He would not stay on his back, and so we pinned him down on his side. And then we examined him. Unbelievably, there was a small spot of blood in the skin of the chest, merely about 1 millimeter in size. We were excited to see something real and opened the chest right next to the spot. The organs were hard to define and they were decaying. The bird had been on that street a long time before I found him, but with the enthusiasm and a bit of blindness to reality, I concluded the bird had died in the fall, broken his rib, which pierced his heart. We interrupted Mr. Rausch's class with the news that we had found the cause of death, a broken heart. They finished without my hearing another word of the lesson. I don't think I knew what a pathologist was, and I'm sure that never once during the autopsy did I think of myself as one. One boy in the class told me his father was a pathologist. That's what I think he called it, but I didn't make that connection. That day I was a surgeon. I had the mask, the gloves, a knife, and a patient to prove it. And from that day on until 20 years later, when I finished my 6-year surgical residency, I never entertained the thought of becoming anything else.
Thank you. Right. Okay, fast forward to 1964. During your 3rd year of medical school, you had some remarkable experiences. You had the opportunity to work in Shiprock, New Mexico, in a hospital on the Navajo Nation. Could you tell us a little bit about that?
Yes. That was the U.S. Public Service health service in Shiprock. It was a small hospital. I wasn't a doctor yet. I was very young, only in my 3rd year. And in looking for a summer internship, basically to get me out of New York for the summer, I was influenced positively by the Navajo healers and their traditions. They were very kind. They tolerated me. They let me participate with them. And I quickly found out that by doing that, by giving them the first shot at the patient, and then bringing them in with my examination and what I planned to give them beyond what they had given them, we could form a team. And we happily did that for the rest of my stay there. We saw the patients together, we cared for them, and I learned a great deal from what I saw, because what wasn't always what I thought it would be.
Can you share one story that was particularly memorable from that time?
Yes, I can. We had a young woman, a Navajo, and she had a terrible urinary tract infection. You look at her urine under the microscope, it had every possible sign of severe disease, and really told us she was experiencing a lot of pain and needed a lot of help right away. So I put her on tetracycline, which was the antibiotic of choice at that time, and these were small oval red caplets, and I sent her out with instructions on how to use them, done through a Navajo translator, and expected her back in a week. When I got her back, I heard she was out in the clinic, and I looked at her urine, and it was completely clear. There wasn't anything to indicate any infection had remained. And then I went to see the patient, and there she was, sitting in her Navajo garb, with a necklace of tetracycline tablets. She hadn't taken one pill. She found them very pretty, and they were, so she made a necklace, and she was cured. I learned a lot from that. I had to move on with my care of the Navajo patients.
And you were quite young.
I was young. I was just in my 3rd year of medical school.
Yeah, not even really a doctor yet.
No, I wasn't a doctor. They called me doctor, but I didn't tell them that was not really.
Moving on to 1972. At the end of your residence training, you were given an opportunity to work in another culture very different than your East Coast life. You worked on the hospital ship Project Hope in Jamaica, when it was docked in Jamaica. How did all of that come about?
Well, my hero and idol when I was growing up was the father of my best friend, Dr. Al Hurwitz. And he was a general surgeon, and he was on the first voyage of the Hope ship very much earlier than where it was then in Kingston. And I'd always wanted to be just like him. His patients loved him. He really was a fine surgeon. He taught, took care of everybody, and he brought me and Rick to the hospital to make rounds with him and see patients. And when I grew up, I wanted to just be him. So when I had the opportunity to get on the Hope ship, this was going to be my first test and seeing if things were really out there in the world that I can do. And it was a wonderful experience. There was something called the counterpart system on the Hope ship, and that was very important. Wherever we went, it wasn't just about taking care of the patients, and then at the end of the year, sailing away, leaving the patients with their old system. Our job was really to do and participate in what they called the counterparts. Every doctor, every nurse, everybody who worked all the way down to the people who swept the floors and cleaned the bathrooms, they all had a counterpart that was there in Kingston. And they would teach them the job that they were doing, so when we left, it would be a full complement for a complete modern hospital with all the people trained to do what they had to do. It was really a fun system. It was very good. It was thought out by a man who could see what was needed, and we did the job with great joy, and it was a pleasure for doing it for 2 months.
Okay, we're moving through the decades. In the 1970s, 80s, and 90s, when you were a practicing surgeon in South Florida, the healthcare delivery system was quite different than it is today. In the 90s, some doctors were selling their medical practices to hospitals, thinking it could be more efficient, something you didn't do. Since then, corporations have started buying hospitals, impacting services. In the 30 years you've been teaching students, because you've been out of practice, what have you been telling your medical students about working in these kinds of new systems?
Well, first of all, I did not join that possibility. They were offered salaries, and then they got a guarantee of seeing patients, and I just stayed doing what I was doing. I was seeing patients who were referred to me, took care of those patients on my own, sent them to other physicians to take care of them when they needed it, but I never joined a system such as that was offered at that time, and I never regretted it. I wanted them to be my own patients and follow them up for as long as they needed me, and send them to the specialists whenever they wanted to or needed to. The other thing that I learned then from another physician at the time was how badly doctors were at listening to their patients. So somebody did a blind study, but the doctors didn't know it was being done, and they timed the amount of time doctors spent with patients and what they did during that time. It turned out, to the horror of just about everybody, including me, the average time listened to a patient after asking a question was 17 seconds before they interrupted the patient and went on with what they were talking about. So this really needed to change. And then there was another great man from McGill who said in these exact words, listen to the patient, they'll tell you the diagnosis. And he went on to talk about it in his writing. He said, just ask the question and just sit back and stop. Don't talk, don't interrupt. These patients may have been waiting months to see you in a crowded place, and they have a lot they want to tell you. And that was such good advice because it worked so well for establishing this relationship with the patient who knew you were going to listen to them and take care of what they thought was important, and then move on to anything else you might have found, instead of ignoring what they initially said and having the patient lost in discomfort with you because you weren't listening. I used to speak to my patients before they were anesthetized and made sure that nobody got put to sleep before I walked into the room. And if they did, which happened once, then they had to be waked up. As far as I was concerned, I wanted to tell them that I was there in the room. I wanted to talk to them before they fell asleep, find out who was waiting, and then ask them what operation I was going to do and for what disease. Fortunately, they were generally the same. Sometimes they didn't understand, and I had time with an awake patient who was not yet anesthetized or narcotized, so they would understand, and I was sure that when they woke up they would know what we had done and why. The other thing I ran into during this time was to realize the importance of the nurses in all of this system. And they were, as far as I'm concerned, way undervalued, underpaid, and never received the true attention they should get. And it was my own campaign, which I still talk about today when I'm talking to medical students and residents, that these are the people that run the hospital. We see the patient, spend some time with the patient, take a history, do a physical, and we're gone. Write some orders, and that may be a half an hour. The nurses are there all day and they're there all night. And they get very little sleep most of the time, and they do the things the patients really need. We may order an IV, they wash a sick patient who can't wash themselves. It's not a great job to have. They take care of all of this. They listen to the patients, they bring them extra food, they do everything they might be getting at home. And we really have to remember that when we ask them to do something for us that might take them away from the patients for a while. And so I try to make that my emphasis all the time with the students and with the residents.
Okay, thank you. One more question from me, and then we'll open up for you. Moving ahead to 2023. In 2023, you were diagnosed with early mild Alzheimer's disease. Can you talk a little bit about why sharing this part of your story matters to you?
Well, it's more than this one story about my own discovery or hearing that I had Alzheimer's, and happily that it was mild and early and I can be treated, and knowing I'm not an expert in Alzheimer's. I'm the patient in this case, and I depend greatly on the doctors. But I wanted to destigmatize that and anything else that the patient might have. Any disease often carries with it, from the patient's point of view and their family, some sort of stigma, as if they might have done something or neglected something, and that's why they were ill. It's almost never the case. Very, very rarely has the patient done anything to warrant them getting an illness that now had to be taken care of. So I wanted them to know this, and I wanted to get this out to them so they could treat the people with all the kindness they had and destigmatize and remove any shame that they might be feeling. And that would be the first really good thing you could do for a patient.
And you're not an expert in Alzheimer's, but you did have training in the physiology of the brain through your own neurological studies in school. But the other thing is, I think, to talk a bit about is Tony's benefited from an early diagnosis, and maybe you could talk about how some of the revolution in the pharmaceuticals have been very helpful for you.
Well, for me specifically, the new drugs that are coming out now and have been coming out for a long time are absolutely incredible. The numbers of them and their potency and accuracy and specificity just increases every day. And it's very important that your physician is very familiar with that, if this is who's treating you, and that you can look forward to more than might be available today. I mean, things have changed in the short time that I've been involved in this, and it's been absolutely remarkable. The changes it's made for me in my life and also for my family.
And that admittedly you benefited from having a later in life diagnosis. Patients with an earlier in life diagnosis often have a very different story, so we're very fortunate in that regard.
We are. I'm in my 80s now, so my life expectancy, in this case happily, is that I'm not going to have to deal a long time with Alzheimer's. I'm going to die before I get to some of the really awful stages. I'm in an early mild stage, well treated by my doctors, and very little has changed other than some short-term memory losses. I can often walk into the kitchen and then stand there for 20 seconds with that memory gone in the 20 seconds before. And then I'll remember what I'm going to do. Long-term memory.
Like us.
So that's the real problem, the big problem for me, and I deal with it, Maribeth deals with it, and my kids all deal with it.
Well, you know, it's one person's story in this book. And as one of our teachers has said, when you've met one person with dementia, you've met one person with dementia. So this is just one person's story, and this is the story that Tony very courageously shared. And in the book, he tells the story, he writes a letter to his family and friends about his diagnosis. And I think if we wrapped up with that and then we'll move into questions, that would just be great.
Talk to me about it.
No, I just want you to read that letter because I think it's a really,
You know which.
yeah. Here it is. It's right there.
Oh,
It's a
thank
short
you.
letter.
Short letter.
This was soon after
You have to
receiving his
stay.
diagnosis.
Dear friends and family, I would like to bring you up to date on some issues that have recently impacted my life and our family's lives. After extensive testing and consultation, I've been diagnosed with a mild cognitive impairment and early Alzheimer's disease. At the moment, I'm functioning nearly normally. However, looking forward, we all know that this is a condition that often gradually worsens over time. Hopefully this will happen very slowly over many years, and since I'm almost 84 years of age, my life expectancy could minimize the changes that have had time to manifest. It's certainly a better outcome and an outlook than if this disease had shown up in my 60s. I'm now writing to you along with a small group of very close friends and family for the eventuality that if the Tony you know now and the Tony you may later know are no longer the same person, I hope you'll understand. As a family, we are speaking out about this diagnosis in a small circle of those near and dear to us, and we appreciate your understanding in this regard. Right now, I'm functioning fairly well, but we know that over time this may very well be bigger changes, and we want to know that you know this and not be confused by my behavior. The family and I are hopeful that the doctors who are managing my case have experience with a strong enough armamentarium of medications and treatments, which over time could normalize to some extent my improvement path for me. For now, I'm able to live my life, live our lives together here in Santa Barbara as fully and richly as possible. I'm deeply grateful for the friends and family who have been an important part of our lives, often over many decades, for the joy that life has been and continues to be, with no other medical or emotional issues interfering with our lives, which is all truly a blessing. Abrazos,